Now, coming to post-testicular azoospermia. Post-testicular azoospermia occurs due to obstructive pathologies and are associated with normal gonadotropin, means the hormones will be normal, and it occurs in 40% of the azoospermic men. Ejaculated dysfunction is also associated with oligospermia or azoospermia, but rarely azoospermia. Obstructive causes includes the congenital absence of vas deferens or ejaculated duct, acquired obstruction, ductal dysfunction, and including retrograde ejaculation. When there is presence of CBAVD, this is congenital bilateral absence of the vas deferens or hypogonadism, men with low volume ejaculate should have a post ejaculatory urine analysis to check for retrograde ejaculation. So whenever a patient comes with this condition, or if the patient is having post testicular azoospermia, then what we do, we order a post ejaculatory urine analysis to see the sperms in the urine sample. And if they are isolated from this sample, then they can be processed for ART or assisted reproductive technologies. Now, how will you diagnose a case of CBAVD or any testicular pathology, varicocele, etc.? You have to order a transrectal ultrasound. Renal imaging can also be done because this CBAVD can be associated with renal agenesis, and same just like this, there is MRKH syndrome in females where we have to rule out the renal abnormalities. Spermatogenesis can be expected to be normal in CBAVD, so diagnostic biopsy is not indicated. At least 2/3 men with CBAVD may have mutation of CFTR gene, and because many CFTR mutations are undetectable, so the carrier status of the female partner should be performed before trying to tell for conception. And tuberculosis can also be detected by transvaginal ultrasound. We can see the bead on string appearance, etc. Now, genetics and male infertility. So CBAVD occurs in cystic fibrosis due to CFTR gene mutation, and the most common defect is delta F508 mutation or R117H mutation. Incidence is 66%. Non-obstructive azoospermia can also be there, where there is no obstruction but there is azoospermia. It can be seen when we do a karyotype, and the genotype is XXY, that is Klinefelter syndrome, and AZFA, AZFB, AZFC. So this is azoospermic factor mutation, and AZFB is the most severe. It is deleted, the DAZ gene is there and it is deleted in azoospermia, so hence there is defect in spermatogenesis. Severe oligospermia, when the count is less than 5 million per ml in the semen sample, we order the karyotype translocation Y chromosome microdeletions, and they can also be detected, but the incidence is very less, 1 to 2% only. Now, stepwise the conditions and their association. So Klinefelter syndrome, where the genotype is 47XXY, there is testosterone deficiency, and they can be associated with perinatal disorders, congenital abnormalities, genetic disorders, respiratory, cardiovascular, endocrine diseases, and malignant neoplasm. Cystic fibrosis, where multiple studies indicate that there is increased risk of tooth enamel defects, permanent teeth, pulmonary defects can be seen because mucus is getting accumulated and cilia is not able to kick it out of the respiratory tract. Pancreatic abnormalities can be there. Now, hypospadias can be associated with urine abnormalities, cryptorchidism, as in testicular cancer, increased risk of testicular cancer in cryptorchidism. Testosterone deficiency, which can be due to diabetes, metabolic syndrome, cardiovascular disease, hypertension, all-cause mortality, CVD, morbidity, mortality, and Alzheimer's disease. And this is associated with peripheral artery disease, rapid bone loss, lung and testicular cancer. Now, if there is vasectomy history in the patient, and you have to do vasectomy reversal and the treatment of obstructive azoospermia. So vasectomy is also a cause of obstructed azoospermia, as we have obstructed the pathway or tied the vas deferens. So vasectomy can be reversed by vasovasostomy or vasoepididymostomy. Patency and subsequent pregnancy rates after vasectomy reversal are 100% 80% respectively. So the patency can be secured in 100% of the cases, and 80% patients can get pregnant. Pregnancy usually occur within 24 months, means it takes 2 years for pregnancy to occur after reversal. Rate of patency in pregnancy vary inversely with the length of time from vasectomy. So if there is duration of 5 years post vasectomy and duration of 3 years after vasectomy, then the pregnancy chances are more in case where there is 3 year duration, not 5 years. Although 60% of the patient reversal develop, anti-sperm antibodies can develop and they do not appear to affect the fecundability. Following surgery, periodic semen analysis should be done, and it can identify reobstruction. Suppose you have recanalized the vas deferens and now post surgery there is reobstruction or the stricture formation or the pathway is blocked, so we have to monitor that through semen analysis, and it can range from 3 to 20% 21% depending on which segments are anastomosed. For patients with azoospermia, 6 months after reversal, the procedure is considered a failure, and testicular sperm extraction with ICSI could be considered. So, if the patient post surgery is not having sperms in the semen sample even after 6 months of the procedure, then we can try TC with ICSI for conception. However, repeated vasovasostomy associated with pregnancy rate of 75%, pregnancy rate of 43%. Now we can also surgically retrieve the sperm and you can use them for ICSI or intracytoplasmic sperm injection. The surgical methods includes MISA. MISA is microsurgical epididymal sperm aspiration, and this process is an open procedure done under GA or regional anesthesia. Testicular sperm extraction, PISA, that is percutaneous epididymal sperm aspiration, can be done under local anesthesia. Percutaneous testicular sperm file needle aspiration, TISA, also called as file needle aspiration, FNA, can also be done. So the processes are MISA, PISA, TC and TISA. Hematoma risk is increased if you are injecting a needle, and because there is chances of varicocele, so the chance of varicocele rupture or hematoma formation is also more. And testicular atrophy is a rare complication of TC and TISA. With obstructive azoospermia, pregnancy rate can be 24 to 64% with sperm retrieval and ICSI, because MISA allowed for diagnosis and possible reconstruction pathologies. So it can lead to sperm cryopreservation, and repeat surgery can be avoided. If repeat sperm retrievals are necessary, the minimum interval between the procedure is 3 to 6 months to allow adequate healing. ICSI is intracytoplasmic sperm injection used for male factor infertility, and outcomes are comparable to conventional IVF. The technique is we directly inject a live sperm into the oocyte, therefore bypassing the limitation imposed by sperm motility and defect in the capacitation, acrosomal reaction, sperm binding the zona pellucida, and it is offered if the sperm count is less than 2 million, sperm motility is less than 5%, and if the sperms have been isolated by surgical recovery. Higher pregnancy rates are there because we are directly injecting the sperm into the oocyte, and the success rate are affected by the age of the female partner and the oocyte quality. Non-male factor indications for ICSI are if there is unexplained infertility, previous fertilization failure with conventional IVF, means IVF has been failed, diminished ovarian reserve, means OVA are already rest, so directly we inject the sperm into the oocyte, fertility preservation and fertilization of oocyte before pre-implantation genetic diagnosis. Now, oocyte regeneration can be seen in 5 to 19% patient of the ICSI, and inherent oocyte quality, ovarian stimulation itself, unexpected random technical problems can be there, the prevalence of sex chromosomal abnormalities can be there, and there is risk of imprinting disorders also in the setting of a specific genetic abnormality such as Y chromosome microdeletion, abnormal karyotype, cystic fibrosis mutation. Genetic counseling should be offered before going for ICSI. Now, there is artificial insemination. This can be done in patients with coital dysfunction or processed sperm into the female genital tract are directly placed, and these sperms are processed before introducing. Because if we do not remove the seminal factors, then it can lead to anaphylactoid reaction. Additionally, processing includes the centrifugation through density gradient, sperm migration protocols, and differential adherence procedures. Finally, phosphodiesterase inhibitors like pentoxifillin can be used during processing to enhance the sperm motility, fertilization capacity, and acrosomal reactivity in IVF procedures. IUI is widely practiced of all insemination technique where we directly inseminate 0.3 to 0.5 ml of washed, processed and concentrated pumps via transcervical catheterization, and patient should remain immobile for approximately 15 minutes. It is difficult to identify an optimal protocol or definitively determine pregnancy rates with IUI, and it should be done if the count is more than 5 million or more than 10 million. So if the count is less than 2 million, then we can offer ICSI. If the count is between 5 to 10 million, then we can offer intrauterine insemination, means there is moderate oligospermia. So the pregnancy rate after intrauterine insemination is 10.5% per cycle and 38% after 4 to 6 cycles. Delivery rate is also higher, 17 versus 8% when more than 2 follicles, more than 15 mm are present compared to 1 follicle. No benefit has been found with double IUI versus single IUI, and fallopian tube sperm perfusion can also be done. What is the timing of IUI? So IUI should be performed 24 hours following the LS surge, because after LS surge there is ovulation. There is no difference in the pregnancy rate if performed between 24 to 60 hours, and IUI pregnancy rate doubles if the SCG trigger was also used instead of natural LS surge. So it is typically performed 36 hours following SCG administration to coincide with the follicle rupture. Donor IUI can be done if the male patient is having azoospermia while the female patient is normal, and this can be done using HMG and controlled ovarian stimulation. High pregnancy rate. If we are doing IUI through donor sperms, the donor sperm screening should be done, and it is in the guidelines. It should be semen should be sampled for HIV, hepatitis B, C, gonorrhea, syphilis, chlamydia and CMV infections, and all cryopreserved samples are quarantined for 6 months. Donor is retested for HIV before clinical use of the specimen. So this is very important, that we directly are not using the semen of the donor. We first check for HIV, hepatitis B, C, syphilis, gonorrhea, chlamydia and CMV, and the sample is preserved, and after 6 months we again check for HIV before clinical use of the specimen. The donor is also checked for genetic diseases like hemophilia, Tay-Sachs disease, thalassemia, cystic fibrosis, congenital adrenal hyperplasia, Huntington disease, and those with a positive family history of these conditions are eliminated as donor candidates. Thank you.